Our final panel member is Richard Kwok from NIEHS. He's going to talk to us about some of the studies related to human health impacts, the studies that are going on right now from Deepwater Horizon. Richard.
Great. Thank you. Good morning. So thanks to Nancy and Kathy and the organizer for organizing a great meeting. I'm here to describe the NIH efforts during the Deepwater Horizon oil spill response to protect human health, and then talk about our efforts moving forward to promote disaster research capabilities and infrastructure to better prepare for future situations. NIEHS has had a long history of involvement in disasters, from the World Trade Center disaster attack, hurricanes Katrina and more recently Sandy, the Elk River chemical spill in West Virginia, and currently ongoing the Ebola outbreak. This includes training and education of the workers, as well as diverse research to understand the environmental health effects of the impacted communities. So the NIH and NIEHS response to the Gulf oil spill demonstrates a novel integrated approach for both intramural and extramural funded investigators. There's really a partnership with workers and numerous community groups to engage in an array of research efforts to better understand the health impacts of the Gulf oil spill. I'm going to talk specifically about the Gulf studies, since that's kind of my group, but we've been involved in a number of other areas. So here's the timeline of the Gulf study activities. You can see, I don't know, a lot of people know much about human studies research, but it requires certain oversight to protect the participants. We need scientific review, institutional review, boards, certificate of confidentialities, and all these take a lot of time to set up. Typically, a study of this size, between with pilot studying efforts and whatnot, take about 3 to 4 years to get up off the ground, and we were able to compress that to a time period of 7 months. The Gulf study moved heaven and earth, and especially OMB, to try to get into the field as quickly as possible. However, you can see that even with this compressed 7-month timeline, much of the cleanup work had already passed by the time we were able to get into the field in March of 2011. You can see that the study is still currently ongoing. We're conducting our follow-up telephone calls now, and then we just recently started the clinical exam, where we're bringing individuals who participated in the first phase of our study into a clinic for more detailed assessments of neurological and respiratory outcomes. So in the end, the Gulf study is an epidemiologic investigation of over 32,000 cleanup workers to look at both the potential short and long-term health effects in a population with the highest potential for physical contact with the oil and dispersants and the mixtures and byproducts of these. Additionally, it's designed for 10 or more years of follow-up. We're looking at telephone interviews, bringing individuals in to clinics. SAMHSA had provided some additional support to these studies to further explore some longitudinal mental health and resiliency outcomes on the impacted populations that are not available with traditional emergency response paradigms, and that really focus only on the acute response. And then we're looking at linkage to vital records and cancer registries, and currently doing the comprehensive exam in about 4,000 individuals in Alabama and Louisiana. In parallel, we funded extramurally the Deepwater Horizon Consortium. So this is a 5-year, $25 million program involving 4 universities and community partnerships with Tulane, LSU, University of Florida, and University of Texas medical branch. So this focus really is on the community and other vulnerable populations. So the consortium's university community partnerships are collaborating on approaches to sharing and disseminating results within the community to better understand the interplay of the effects of the multiple stressors on human health. For instance, we're looking at contaminants in the air, the water, seafood, examining factors in individual and community resiliency, and then assessing the relationship of these and other stressors and its impact on human health. Some of the challenges that we encountered in conducting the still is really who's affected. Are we able to contact these individuals? BP and NIOSH and others spent a lot of time and effort to roster individuals, combining, getting lists of those who worked. And so we were able to kind of take advantage of some of those efforts, so from BP, from the Coast Guard, from NIOSH, U.S. Fish and Wildlife Service. BP had hired a contractor, the response group, or TRG, to badge workers as they went onto site. But unfortunately, it was only like months afterwards that we find out that the offshore rig workers never had to go through that process. And so, we had flight logs and these POB lists of the vessels, but they didn't have contact information for these individuals. So John Smith, who worked at Able Body, it was difficult to contact, especially when employers were uncooperative in terms of providing contact information or even disseminating this information to employees. We tried going through the TWIC process through TSA to access the contact information for some of these individuals, but due to the Privacy Act, we weren't able to get that information. So thinking about research at the beginning when they're developing the process in the acute response phase would have been very helpful to try to get information about who exactly was affected and who these oil spill response workers were, because these weren't the HAZWOPers, these professionals that were trained. These are college students home from the summer. These were unemployed fishermen. These are unemployed oil spill workers, community members that were concerned. These were the folks in the Vessels Opportunity Program that were participating in the spill, and were very difficult to contact after the fact. The study development process, there's processes in place to protect human subjects, but these take a lot of time. And in a disaster response scenario, when you're working on a time scale of minutes and hours, months and weeks, it won't cut it. And then having a baseline data for comparison was very difficult because it really was only available for a very small fraction of the coast of the Corps. For instance, just the Coast Guards that had these annual physicals. And a lot of health information, biospecimens, and relevant tests weren't available pre-spill that we were able to then compare. The exposure reconstruction, multiple databases need to be integrated, and the available data that were difficult to use to reconstruct individual exposures. The data were really collected more from like a regulatory standpoint, not from an individual research, exposure, dose reconstruction standpoint. And then also the time, as Chris had mentioned yesterday, the timeliness of the extramural awards and initiation of studies. It takes time for academia to kind of get set up and get the wheels moving. And so we don't have a similar mechanism like NSF to provide funds for extramural investigators to get out into the field quickly. So recognizing this, these scenarios, we needed timely systematic data collection by design, right up off the bat. And so building on the acute response and surveillance to set up these cohorts for longitudinal research. So we need baseline data instead of ad hoc data collection. Need thoughtful, systematic data collection. That's representative of the population at risk, of the cohorts that are involved. We need exposure data that are collected for research and not just for regulatory purposes. We need to look at high-risk groups, not just a convenience sample that you're standing on the dock and just getting workers as they're coming off shift and collecting baseline questionnaires and rostering information from these individuals that target the entire population at risk, so we can kind of have a better understanding, both of the folks who have high exposures but also low exposures. The CASPER that was done by CDC was helpful because it was acute. It was helpful for acute assessment of mental health outcomes, but we need to be able to look at, to follow up these individuals longitudinally to see what the changes are over time. There's also toxicology data, starting with the Elk River, West Virginia, there was very little toxicology information in dispersants and oil. And so, we're looking at collaboration with NTP, which is collaboration with NIOSH, FDA, and NIEHS, to look at the role of mixtures and characterizing the different potential risks of these mixtures on individuals. And really need to engage the community, having open communication with the community, need relationships. You can't just come in as the federal government and say, we're going to save the day. There's a lot of distrust in some of these communities that having an established relationship would be very valuable, especially in vulnerable populations. So based on these lessons learned from our oil spill research efforts and other recent disasters, Dr. Collins, the NIH director, Nikki Lurie, who's the department level assistant secretary for preparedness and response, and Tom Frieden, the CDC director, outlined a need for improved national capabilities to perform critical health research during disasters and other emergencies. Of note, it took 9 months or 7 months to start our research efforts in the Deepwater Horizon, 12 months to start the Deepwater Horizon Research Consortium, 11 months to fund the Hurricane Sandy research, and we missed this valuable window of time that we can, contact individuals to measure the health effects, and get valuable information, so that can inform public health. So in response, NIEHS, in collaboration with the National Library of Medicine, started a new disaster research response, or the DR2 project. This project was initiated with seed funding from the NIH director's discretionary funds to enhance the timely collection of human health data in response to disasters. So the DR2 project was started in August of last year and is currently ongoing. So over the past year, the DR2 has worked to develop new disaster research capabilities to shorten the timeline to conduct research by curating a central repository for these data collection tools to facilitate data collection of environmental health issues. So what are the relevant questions that you need to ask in a disaster, in an oil spill scenario, in a tsunami, in an earthquake, in a public health outbreak, and so make these accessible via a public website that folks can go to and then quickly modify and pull off what they need to be able to kind of put together a questionnaire that both addresses the acute needs of the research, but also longitudinally for research that we're able to then follow up with. And also, creating a new NIH disaster response plug-and-play protocol. So what exactly, to quickly acquire baseline epidemiologic data, medical information, and biospecimens to engage the NIEHS IRB to have these pre-approved protocols in place to shorten the approval process so that it won't take months to get into the field, maybe hours or days instead. We're working to establish an environmental EHS network of grantees, so mainly the NIEHS core centers, Superfund centers, children's centers. So these are academic institutions that are already working across the nation to develop a network of trained research responders. So in case something happens in their backyard, that they would be better positioned to respond to these disasters. And we're conducting training and refining of skills. We hosted a training exercise in Los Angeles for over 140 stakeholders, including federal, state, local health and environmental and emergency management officials to test the DR2's tools and strategies. And then also, share and integrate this information across the federal, agencies. We sponsored a 2-day workshop this past summer in DC, which was in collaboration with the ASPR, the National Library of Medicine, CDC, and the Institute of Medicine. Had over 230 participants from across federal, state, academia, NGOs, and private industry to discuss disaster-related research issues and other opportunities. Improve how we get toxicology data. So for example, we have ample amounts of source oil B from the enterprise, with some additives, that were provided to us by BP, but we're never really successful in obtaining something close to virgin MC252 oil or quality weathered oil samples. So if someone out there has access to some of these samples, I'd be very interested to talk to you, and collaborate in terms of getting access to some of those samples. And also we need to systematically collect environmental exposure data that can be used in human studies. So we need research grade versus regulatory grade information. Just an example of this, BP collected a lot of ambient air monitoring data, but they analyzed it using an occupational exposure limit, and not the methods limit of detection. So we had a lot of left censoring data that that from an occupational standpoint, you don't really care about because it's below occupational limits you don't really need. But for environmentally, you can go an order of magnitude below that level to be able to discern any potential health effects. So the disaster research, DR2, looking forward, we have plans to improve the DR2. There's a lot of obstacles and challenges, and it's evident that these situations will continue to arise. And so we need to look forward with our efforts to improve our capabilities to collect time-sensitive information to protect the public health and to save lives. And so we have plans for improvements in the DR2 repository and how our web-based information and tools are provided to the public and to researchers, and also additional training exercises and new activities to promote the timely acquisition of environmental and toxicology data to complement the collection of health information in response to disasters. We will be planning several training exercises coming up for next year, the first of which will actually be in February in conjunction with the GOMRI meeting in Houston. And then also think about new collaborations using the RAPID protocol, new collaborations between government, academia, and the community to be all active participants for success. The IRB is working now to look at best practices, working with community members, to try to shorten the review process and develop the right kinds of consent forms so that people that are reflective of being in a disaster and studying these vulnerable populations and also to build up and expand this EHS network to help identify and prioritize focus areas for environmental health disaster research, to evaluate the different tools and products being developed by the research community, and to help create a novel collection of EHS researchers and community partnerships around the U.S. that can facilitate and conduct research in response to environmental threats and disasters. And so really, we have exercises to further test the research response strategies. For instance, last year we had a partnership with USGS and California officials on a tsunami exercise in LA, and also planning in Houston and GOMRI next year. And lastly, we need to continue to advocate for needed resources and infrastructure to develop and support an effective research response system, engaging new technologies using social media and citizen science in research and how that can be used. So that's all the time I have. And if you have any additional questions, feel free to contact me or Aubrey Miller, who's leading the DR2 research efforts. And there's the link to the webpage for more information about the DR2. Thank you.